Hello, I'm John Halamka, the president of Mayo Clinic Platform. I joined Mayo Clinic about 2 years ago to oversee a very large amount of data, AI, and digital transformation. And along that journey, you have to ask several questions. If we are going to develop new cures, if we're going to put the patient first, how do we take this large amount of historical data and use the patients of the past to equitably treat the patients of the future? This turns out to be a really tricky problem. So this is of course not a real example, but I'm going to give it purely to illustrate the point. So imagine we are going to create the world's best EKG algorithm. It's going to be able to take data from your heartbeat and be able to diagnose disease that a, say, physician can't actually see on that 1, 6, or 12 lead ECG. And we're going to do this on 1 million Scandinavian Lutherans. I mean, after all, Minnesota may have a few of those. And then we're going to take that algorithm and we're going to run it in Spain. Is it going to be effective? Useful for purpose? Is it going to underdiagnose? Is it going to overdiagnose? Do we know? And this is the problem. So much of the analytics we're doing today, such as Bayesian or AI-based systems, are a bit of a black box. And that is, in fact, when you lift them off the shelf and you put them into your electronic health record or some other aspect of workflow, you may not know what is being measured, and you may not know the predicted result or effectiveness for the patient who's sitting in front of you. So what do we need to do? Well, certainly I would argue first, you need to have great curated multimodal data. Again, what do I mean by that? So if you look at today's electronic health record and you look at such variables as social determinants of health or race ethnicity, you'll see a couple of problems. So first, a lot of that data is sparsely populated. And by sparsely populated, what I mean is it may not be complete. It may not have been thoughtfully completed in a way that reflects the patient's belief of their own social determinants of health or race, ethnicity, or other variables. And an interesting issue with such things that is categorical race or ethnicity, what is ground truth? Are those variables, as we record them today, granular enough to actually use in some kind of predictive model? And I could actually argue they're not. And I mean, again, this is just a somewhat inaccurate example, but my mother was born in Riga, Latvia. My father was born in Prague. My wife was born in Korea. So what is the race ethnicity of my daughter? Right? Very complicated question if you're going to create a mathematical model based on some category. So I think our ground truth needs to be multimodal. That is, we need to gather a whole variety of data sources to understand the person, the patient, the care they need, and ensure that care is equitable. What you're going to see over these next 6 quarters is more and more non-traditional sources of data being gathered. And so that is, it's not only EHR data, but it's data about the neighborhood in which you live. What are your, say, accesses to public transportation, education, good food? Are there issues of, say, air and water contamination? Right? All these things coming together help us understand the nature of the phenotype, the genotype, and what I'll call the exposome, where you live and where you work and what you experience. Once we understand all that, and then we create AI models, we need to validate those models. We need to make sure that there is some kind of objective measure, an objective laboratory that says, oh, well, this model has the following characteristics, an AUC, an area under the curve of performance when used on patients like this. And oh, here's how the model was trained. Here's how the model was validated. So what I would suggest, when you buy a can of soup, you can look at a soup label and say, oh, well, this has 500 milligrams of sodium and 50 grams of fat. I don't want that soup. Shouldn't every AI algorithm produced for healthcare, in fact, really for any industry, have a soup label on it that says, well, this is a convolutional neural network. Here is the population. We use 60,000 people, and here are some of the characteristics about the people that we used. And here is its performance, generally, or when stratified by some subset of that population. Mayo Clinic has established an international consortium of thought leaders that over the next few quarters will begin work on creating what we hope will become the standardized soup label for all AI algorithms across industries. In fact, we hope that publications, journals, won't accept a research study unless there is such a label on the AI algorithm that was employed. Mayo Clinic has tried over the course of its last couple of years to create what I'll call a federation of data sources. And by federation, what I mean is if we have the data of Minnesota and Arizona and Florida, 10 million patients, I mean, certainly that's a start. But don't we need to have patients in different geographies and different neighborhoods? And shouldn't we develop AI algorithms, not even based on the 10 million patients of one institution? Shouldn't we be able to reach into the data in a privacy-protecting, ethical fashion of colleagues throughout the world? So you'll see again over the next several quarters, Mayo has invested in several new technologies that enable us to create federations of data sharing while ensuring that data is completely secure and privacy protected, to develop algorithms that are in themselves intellectual property protected. And I tell you all this about privacy and intellectual property because as we innovate as a society, sometimes there are barriers that are technological. Sometimes there are barriers that are regulatory. Policy doesn't allow certain kinds of data use. But sometimes there are issues that are more behavioral. Oh, this sounds risky, or I'm not sure I want to do that because I have fear of loss of reputation if the data might get compromised in some way. So by putting into place these technological controls, using these innovative technologies in a way that can federate data and generate new algorithms, we hope to have algorithms more fit for purpose, algorithms that are more locally tuned to the patient in front of you. A quick example of locally tuned. Some years ago, I was chatting with a senior executive at Microsoft, and he said, oh, we took a huge amount of data, we developed some amazing AI models, and then we took them 2 blocks down the street and found they didn't work. And why was that? Well, the population for the algorithm development was Medicare patients, and then 2 blocks down the street, there were a lot of Medicaid patients. And therefore, it turns out the nature of the population was different enough that the algorithm really didn't perform. And so sometimes what we'll find is even with our best efforts, even with federation, there will still need to be local adjustment and tuning, and we need to think about regulatory frameworks and technical frameworks to allow that. So what I hope I've given you today is a sense that the future is bright, and we're going to use the data of the past with appropriate consent and privacy controls to help predict the best care path for patients of the future. But we need to do so with guardrails, best practices, and working together to ensure what we do is equitable and useful to always put the patient first. So as we talk about the development of AI algorithms based on great curated data, how is it we even accomplish that? Well, the way Mayo Clinic has thought about this is in 4 distinct product lines. So the first being, we need to gather the information from not only traditional healthcare sources of data or billing data, but also from the devices that you wear, the devices in your home, the devices that you carry. So, for example, there's a huge amount of what I'll call digital exhaust that comes from this. How actually did you tweet or look at Facebook today? How many emails did you send? Did you walk? How many times did you pick up your phone? Now, why do we even suggest that's an interesting data source? Well, if you're looking, for example, at anxiety and depression, and you see a huge differential change in the way a person uses the digital devices that they own, this could be an indicator that there is acute exacerbation. So I tell you all that because we've created a set of activities we call Gather. And it's about taking a lot of non-traditional data sources, curating them, cleaning them up, making sure there's signal and getting rid of noise, making sure they're fit for purpose, and then adding them to the longitudinal patient experience. So with the use of these gather approaches, we end up with structured data and unstructured data from electronic health records or billing systems. But then we end up with telemetry. I mean, you may wear a watch that gathers your EKG or your pulse oximetry, image data, omics data, and various other kinds of digital indicators about you and your life. Again, all gathered, of course, with consent. So gather, that's a really important first step. Second step we call discover. And the challenge with all this data, you have to assemble it in a longitudinal way. Much of our healthcare data is organized in episodes of care. You went to an ambulatory visit or you went to a hospitalization. But if we're going to develop models about care journeys, we better understand longitudinally your experience over a lifetime. So working with cloud computing providers, we have organized all of this multimodal data, about 60 petabytes of data, into a de-identified but yet longitudinally arranged data store. De-identification is pretty hard. So sure, if we follow the HIPAA guidelines and we remove 18 identifiers, your name, your address, your phone number, well, that's one kind of DID. But imagine that there's a note that says, and this Massachusetts senator. Well, the problem is there are only 2 senators. It's not very de-identified, is it? So we have had used natural language processing to be able to remove job roles, family relationships, or geographies from the data, so that you could say that this very large data store is really challenging to re-identify. But even that's not enough. Some years ago, one of my colleagues was able to link a voter registration database and a de-identified clinical database to re-identify the governor of the state. So we have to prohibit linkage of external databases with the de-identified data. We have to control the use of that data. We call this data behind glass. De-identified, placed in the cloud, and then under our control, under our auditing, we then bring innovators, we bring companies and other academic organizations into our cloud container, where tooling brought by those companies or individuals can be used for AI development and new discovery. So de-identified multimodal data behind glass is an ethical approach that enables discovery without losing control. And then the validation of these algorithms. So working with several companies, we have developed the means for creating this soup label that I mentioned by taking any algorithm, Mayo or not Mayo, Mayo data or not Mayo data, and being able to bring the two together, the data and the algorithm, and produce a result, which then can be used as a way for anyone who wants to reuse that algorithm to understand it better. And then finally, we recognize we need to deliver the result of our AI algorithms in workflow. I will tell you this, I'm a clinician, an emergency physician. Telling a clinician they're going to spend even more time in their EHR or have to deal with more things in their inbox or get more alerts isn't helpful. So the question is where in the workflow can you introduce the results of these AI algorithms in a way that doesn't enhance burden, but augments human decision-making? So for example, 5 of our algorithms that augment EKG or ECG interpretation actually simply print on the ECG. So hey, you're looking at the ECG anyway, and now, it says the algorithm concludes you don't have a weak heart pump, pulmonary hypertension, hypertrophic cardiomyopathy, or even an acute COVID infection. It's just right there in front of you as part of your standard workflow. Or sometimes we add AI algorithm output to dashboards. These dashboards actually may be looked at by care managers, nurses or mid-levels, paramedics in the community. It isn't about burdening clinicians moment to moment with more data and more distractions. So that's deliver. So with gather, discover, validate, and deliver, we end up with a framework that gives Mayo Clinic and multiple joint ventures, collaborations, and partnerships throughout the world an opportunity to use AI to its fullest extent. Our Bold Forward 2030 plan is all about radical change and innovation in the healthcare system while following the highest standards of ethical guidelines and focusing on equity. And we believe our approach, this technological approach, but bounded by so much of the Mayo Clinic values and history, is going to make not only Mayo Clinic successful, but everyone in the healthcare industry as successful as possible.